we're going to talk about 4 very interesting cases which presented not typically. And you know that hypertension presentation in children is often vague. So they presented in different manner. And then at the end, we found very interesting diagnosis. So this is the whole spectrum. So when we talk about hypertension or blood pressure regulation, there are 2 major factors which are there. One, of course, is how much is the cardiac output and how much is the peripheral vascular resistance. So these are the 2 major determinants, and many of the endocrine factors will play a role in that perspective. So we know that calcium is a major stimulant as far as the vascular constriction is concerned, and that is why calcium channel blockers are used for management of hypertension. We know that the fluid is largely regulated by multiple endocrine systems. And important factors, of course, are the sodium and the growth hormone. Both play an important role in the fluid regulation per se. Then cardiac contractility and the heart rate is determined largely via the thyroid function. So there are multiple endocrine organs beyond the adrenals which are also involved in the whole perspective. Coming on to the most important part, of course, is the renin, angiotensin, aldosterone system, in which renin basically converts the angiotensin, and then we have the ACE converting into angiotensin 2, which triggers the adrenal production of aldosterone, which is a primary regulator of sodium absorption in the body. Now, adrenals also produce cortisol, which are the trigger as far as catecholamine production. So overall blood pressure regulation involves a number of hormones, and disorders there could cause what we can say, quote unquote, endocrine hypertension. So we all are aware about thyrotoxicosis, increased renin state, which can cause that, hyperaldosteronism, which can be primary or secondary, Cushing syndrome or cortisol excess, excessive catecholamine production like pheochromocytoma, of course, will cause that. And we also know that hypercalcemia and hyperparathyroidism and growth hormone excess can also cause this. So a large number of endocrine disorders are important factors as far as hypertension is concerned. Most of them, be it thyrotoxicosis, be it hypercalcemia, be it growth hormone excess, the symptoms will be clear. The symptoms may actually be quite vague for a aldosterone producing tumor, and this is what we're going to focus more in terms of what we can say, quote unquote, increased aldosterone effect. So either the aldosterone is more, or there is another molecule which is behaving like aldosterone acting on the receptor, or the receptor itself is hyperactive. So that becomes important. So when we talk about increased aldosterone effect, the situation can start right from the production of renin. So you can have scenarios in which there is increased renin production. The classical example we all know is a renal artery stenosis, in which the kidneys feel that there is no blood flow and they are going to push a lot of renin to increase the perfusion, causing hypertension. There could be issues at the level of adrenals, which are producing more aldosterone. And this production can be because of an isolated adrenal adenoma, adrenal hyperplasia, or what we call as a glucocorticoid remediable aldosteronism, which is basically a splicing defect in which the regulation of aldosterone secretion happens via ACTH, and that is going to control that. We can, of course, have a problem in the 11 beta HSD2, which basically shields the mineralocorticoid responsive tissue from the impact of cortisol. So if there is a 11 beta HSD deficiency, like apparent mineralocorticoid excess, you can have a scenario. And similarly, of course, in Cushing's, you have got so much level of cortisol, particularly if it's an ectopic form, which is there. In those scenarios, you may have hypertension, hypokalemic alkalosis, which will happen. So that is actually a apparent mineralocorticoid excess scenario. You can also have increased activation of the epithelial sodium chloride channel, and this also is going to trigger increased activity. The classical example is Liddle syndrome, in which the epithelial sodium chloride channel is more working. You are absorbing more sodium, causing hypertension in that regards. As I said, you can also have aldosterone-like molecule, which have got mineralocorticoid activity. The classical example is DOC, which may be produced in the setting of CAH variants like 11-hydroxylase and 17-hydroxylase. 11-hydroxylase will classically present with XX-DSD and precocious puberty in boys. 17-hydroxylase will present more with XY-DSD and delayed puberty in girls. So these are the overall gamut of scenarios which may be causing an increased aldosterone effect. The problems could be because of a true increase in aldosterone, which would basically be either an adenoma or a hyperplasia. There could be a familial cause like glucocorticoid remediable aldosteronism, which I said is because of the regulation of aldosterone production via ACTH. So it's an unusual production regulation via ACTH. Then you can have a DOC excess because of a tumor or 11 or 17 hydroxylase deficiency. And then finally, you may have no increase in aldosterone, but there is an apparent excess because there is decreased conversion of cortisol to cortisone, resulting in apparent mineralocorticoid excess or a Liddle syndrome. So we'll be discussing about probably 5 to 6 cases if we get time, but there are 4 key cases which will focus about pretty much starting right from adenoma to 17 hydroxylase deficiency to 11 beta HSD deficiency and a level higher also about renal artery stenosis. So we'll talk about a lot of these constellations approaches from that perspective. All of you can go and have a look at our website, learning.gosociety.in, which has got a lot of free resources as well as courses and fellowship programs and diploma in endocrinology, which are available. We do run around 3 programs a month with regards to the journal club, the postgraduate lecture series, and the grand rounds covering these aspects. There are publications which are available both online as well as hard copies and mobile application which can be used for access and point of care. So what we'll do today is to focus about 4 cases after we have the basic understanding of approach so that it becomes easier. So we'll talk about a case of high renin, then adrenal mass, recurrent stroke, and hypertension with nephrocalcinosis. These are 4 very interesting cases. If we get time, we'll talk a bit about 11 hydroxylase and 17 also as case vignettes in that regards. So now in this background of the overall approach for these causes, the questions are, is it really an increased aldosterone effect? If it is an increased aldosterone effect, is it because of an aldosterone excess or an apparent excess? And finally, what is the cause? So as we have discussed that hypertension is particularly common in older individuals. But if you have a young individual and there is a hypertension, we are always worried about that. So if there is an onset of hypertension before 20 years of age, and in children, we know that first you have to exclude all the renal parenchymal and the renovascular causes. Once you have done that, you can think of pheochromocytoma, you can think of coarctation of aorta, then you're talking about an endocrine cause or a low renin cause of hypertension. However, it has now been identified that around 5% of what we call quote unquote essential hypertension in adults is actually because of aldosterone excess. So if you have onset after 20 years also, but requiring 3 or more medications, you have to worry about that this could be a secondary hypertension and do a basic screening for the aldosterone excess in that regards. Now, within a group of individuals who have hypertension, if they have frequent muscle cramps, which basically would mean hypokalemia or hypomagnesemia, if they have features of polyuria and failure to thrive, strong family history, particularly for the autosomal dominant variant, which is the glucocorticoid remediable aldosteronism, and as I said, polyuria and hypokalemic alkalosis, you are thinking more in terms of endocrine hypertension. Now, one concept often people have that everybody who has got a hypokalemia, we are going to think about aldosterone excess. So if the potassium is normal, the chance of aldosterone excess is less. This is untrue. A large number of patients who actually have endocrine hypertension may have normal potassium. And this is an important message to consider, that you have to consider even if the potassium is normal. If the potassium is low, you definitely have to worry, but normal potassium does not exclude the possibility of this group of disorders in that perspective, and that becomes important from that regards. Now, how do we, once we have decided that this is possibly a renin-angiotensin effect, how do you assess the scenarios from there? So essentially, we have already discussed that we have got angiotensinogen, which is converted via renin to angiotensin 1, which is converted via the angiotensin converting enzyme to angiotensin 2, which actually is a very, very important agent as far as fluid regulation is concerned. Angiotensin 2 causes vasoconstriction, increasing blood pressure. It increases aldosterone secretion. It increases thirst. So it has got multiple mechanisms by which it is acting to increase the fluid status overall from that perspective. And this aldosterone will then cause action on the mineralocorticoid receptor to assess. So if we talk about the renin-angiotensin-aldosterone system, the assessment can be done at the level of actual measurement of renin, which is a direct renin assessment, or a plasma renin activity. Now, direct renin is basically an immunoassay. Plasma renin activity is actually a bioassay. So we need to be careful when we differentiate. We'll talk a bit about how they are different and which is preferable in that regards. We, of course, have to measure aldosterone in combination with renin, like we say FT4 TSH, ACTH cortisol, insulin glucose, calcium PTH. Same is that aldo has to be combined with renin to get any meaningful result in that perspective. So the screening investigation essentially for anybody whom you're thinking of endocrine hypertension is an aldosterone along with renin level. Now, what you need to be cautious about that this should be done ideally in the morning around 8 a.m., 2 hours after the patient has waken up. Very importantly, 5 to 15 minutes of sitting posture is important. And because if you're doing particularly a plasma renin activity, which is a bioassay, you should use a pre-chilled tube. Otherwise, you will have a falsely declined level as far as the renin is concerned. Now, we all know that there are two types of assays available. One is the renin and other is the direct renin content. So plasma renin activity is basically a bioassay, and direct renin is essentially a form of an immunoassay in which you are measuring the renin content in that perspective. Now, very importantly, the renin activity will depend upon angiotensinogen, how much angiotensinogen is available there, and it is not affected via estrogen. So the major differences is if you talk about cyclical variation, you will have much more variation which happens in direct renin content as against a plasma renin activity. So during ovulation, if you want to look at PRA will be a much better strategy rather than a direct renin content from that perspective. Moreover, the assays are more robust for plasma renin activity. So most of us will go for plasma renin rather than a direct content. But if you are going with either of them, remember the ratios will be different. The aldosterone to renin ratio will be different and your interpretation will vary also from that perspective. So this is something important to identify what your lab is doing and how do you want to assay from that perspective. Very importantly, if somebody is restricting salt, or in a standing state, you will have an elevation of renin. Levels are typically highest in morning, and renal failure, of course, is a scenario where your renin will be less because it is being produced by the kidneys also in that perspective. Now, another very important problem which happens in these scenarios is that many of these patients are already on many medications. So what is the impact of those medications when you are assessing the aldosterone-renin ratio? Because otherwise, you will get a false positive or a false negative result in that perspective. So if you have intake of spironolactone, essentially we're talking about calcium channel blockers, ACE inhibitors, ARB and spironolactone, all of them will suppress in a way aldosterone activity. So that will falsely give renin levels which will be high. So you will miss primary hyperaldosteronism. On the other hand, if your renin is still low, in somebody who is on ACE inhibitor, on ARB or spironolactone, you are 100% sure that this is a low renin or an endocrine pattern of hypertension. If somebody is on sympathetolytic agents, if you are beta blockers, central agents like clonidine, methyl dopa, these are all going to inhibit the central sympathetic trigger. So therefore, you will have a low level of renin, and because renin goes low, your aldosterone to renin ratio will go up. And you will falsely label somebody, okay, he does not have primary hyperaldosteronism, but you will say this is primary hyperaldosteronism. So these drugs should be avoided in that perspective. Direct renin inhibitor is not very commonly used now. That also causes a confusing scenario in which your PRA is less because you are antagonizing renin. So your bioactivity is less, but your immunoactivity is normal, because your renin content will be normal, but this is something which is not really commonly used in that perspective. So what do? We shift them to drugs which do not affect these ratios, which could pretty much be an alpha blocker like prazosin or a calcium channel blocker like verapamil, which can be there. So prazosin is a good drug to start off in that perspective. Now, very importantly, if somebody is on spironolactone, somebody is on ACE inhibitor, somebody who is on ARB, you expect them to develop hyperkalemia. If they are hypokalemic, then that is something that this is actually overriding the effect. This is 100% sure that this is an endocrine form of hypertension or renin excess, which is there in that perspective. Now, when you're assessing the RAS system, you need to remember that like FT4 and TSH, like calcium and PTH, like glucose and insulin, there is a log linear relationship between aldosterone and renin activity. If your aldosterone level goes up, renin should be zero. So you have to basically correlate between aldosterone and renin, and they have to be done parallelly in that perspective. So if aldosterone is high, PRA level should ideally be low in that perspective. This is primary hyperaldosteronism. If, however, your PRA is high, it means renin is driving the whole picture. And this would mean something like a renal artery stenosis sort of a scenario. Now, how do you interpret this? So what I'm doing now is to use PRA, plasma renin activity, which is more commonly used. And I would prefer that because it's a better bioassay. And the ratio between aldosterone and plasma renin activity, which is ARR, or plasma aldosterone to plasma renin ratio. If aldo is more than 10 and renin is undetectable. So theoretically, whenever we say your FT4 is high, TSH should be 0. If your aldo is high, your renin should be 0. This is classically primary hyperaldosteronism. You don't need to worry about this in a great extent. However, if the renin is high and the aldosterone to renin ratio is less than 10, this suggests a hyperrenemic state. And we'll talk about both scenarios. If both of them are low, this means that there is some other form of mineralocorticoid which is acting, which could be a DOC, or there is an apparent mineralocorticoid excess, or Liddle syndrome. These are the possibilities which will be there from that regards. So now if we compare the common etiology in the form of renal artery stenosis, adrenal adenoma, or hyperplasia, these are pretty similar. GRA, these three will be similar. CAH variants, AME and Liddle, renin level will be low in everybody except a renal artery stenosis. So in this scenario, your renin is high because that is driving the overall picture. If we talk now about the aldosterone level, the levels will be high in everybody except for apparent mineralocorticoid excess, Liddle syndrome, and CAH variant. So if you have low renin, low aldo, you're talking about either DOC or you're talking about 11 beta HSD or Liddle syndrome. And finally, if you have renal artery stenosis, CT angio will give you a clue. For adrenal adenoma hyperplasia, CT becomes important. For CAH variants, as we'll discuss, there would be the option of doing the specific metabolites. For AME and Liddle, you can use the impact of spironolactone. Now, if somebody is responding to spironolactone, it suggests an apparent mineralocorticoid excess. If they are not responding, this suggests a Liddle syndrome. And now, of course, genetic diagnosis can also give you the precise diagnosis in the form of a clinical exome sequencing, which you can do. So the approach to an individual who presents to us with suspected endocrine hypertension is to look at the renin level. If the renin level is high, possibility is renal artery stenosis, go for a CT angio. If the renin level is low, go for DOC level. If DOC is high, this is 11 or 17 hydroxylase deficiency, go for a tumor, go for CT and genetics. If you have got low DOC and your aldosterone is high, this is primary hyperaldosteronism. So low renin, high aldo, then you go for CT, and then young patient, family history of recurrent strokes, think of a GRA. So response to steroid will be significant. If you have got a low renin, low DOC, low aldosterone, this is either two differentials. You're thinking of either an apparent mineralocorticoid excess or a Liddle syndrome. Look for spironolactone response. If it's there, it's most likely a 11 beta HSD2 defect, which is apparent mineralocorticoid excess. In this case, you can do a genetic study. And if you have got no response, this is most likely a Liddle syndrome and you have to go for a genetic study. So basically, go for a combination of renin and aldosterone. These two will give you a clue. DOC will also be helpful, and then spironolactone response. High renin, renal artery stenosis, low renin, high DOC. You got specific diagnosis, but you will get clues. If there is a XX DSD, think 11. If it's a XY DSD, think of a 17. If, however, these are not there and your LDO is high, look for an adrenal tumor. If your LDO is low, look for spironolactone response and you will get the diagnosis.
We had 9-year-old boy, Master V, who presented to us with complaints of on and off headache for last 1 month, predominantly frontal, lasting moderate to severe in intensity, lasting for a variable duration of time, with an acute episode of loss of consciousness and generalized convulsions. At triage, he had a heart rate of 82, respiratory rate of 18. Perfusion was essentially normal, but BP recorded was 180 by 100. His saturation was normal. Initially, he presented with a GTCS, but post-abortion of seizure, his sensorium was E3V3M5, and pupils were 3 millimeters reactive to light. On gross examination, he had no dysmorphism on urocutaneous markers, and he was a well-thriving child. His weight and height were within the normal range.
So his hypertension was diagnosed at the treating physician, or was it picked up later on?
It was actually picked up not immediately at triage, maybe, but yes, during hospital stay.
But they have mentioned as an acute encephalitic syndrome as a diagnosis.
Yes.
This is something which you have to very, from a pediatrician perspective, the manifestations of acute hypertension may be variable. That is beyond the scope of this discussion, but definitely, if you see all the cases, they will have different sort of a presentation. So this child actually presented with what was labeled as query encephalopathy.
Yes.
So this was something which we have to be wary about, that in those situations measure the blood pressure. So I think they had missed the blood pressure in the
initially,
beginning,
yes.
and then it was picked up later on and then worked upwards, done from that perspective. So you have a child who has significant hypertension, and probably hypertension is causing the encephalopathy.
Yes. So in presence of hypertension and further history was elicited, we found that he was born at term, had a normal birth weight, he was well thriving, developmentally normal, had no previous illnesses or drug exposure, he had no history of recurrent UTI or abdominal symptoms or any skin abnormalities, and there was no family history of an early onset hypertension.
So what are the specific points that we discussed, that when you have hypertension below 20 years of age, of course you have to look for secondary causes. But anything you were looking specifically for endocrine causes that you would like to ask in this slide, honestly?
So, among the endocrine causes, yes, one would definitely want to look at if there was history of weight loss in the preceding few months, history of palpitation, restlessness that one has, or if the child has progressive weight gain with presence of stria on abdomen, if that is something they've noticed.
Anything else on history? One would be polyuria.
Yes.
If there is a polyuria, if there is a myopathy, if there is cramp, that will become important. And then, of course, if there is episodic features of the spell-like features, although pheochromocytoma is usually causes a persistent hypertension, but if you get a clue that there is a postural hypertension, there is a plethora which happens intermittently, there is a cold hand, sweats, all those things can be. So you have to basically, from an endocrine perspective, look for polyuria, failure to thrive, features of Cushing syndrome, and features of pheochromocytoma.
So defining pediatric hypertension, BP less than 90th centile for age, gender, and height is normal, and anything more than 90th is an elevated BP, with stage 1 hypertension defined as between 95th to 95th plus 12, and stage 2 as more than 95th plus 12 centile. For adolescents, the cutoffs are pretty much similar to the adult cutoffs. And when you have a child with hypertension, the important things that you need to look for on general examination is edema, which may point towards a nephrotic syndrome child presenting to you with hypertension or Cushingoid appearance. A growth retardation will point towards maybe a chronic kidney disease. Anthropometric measurements, again, you need to know the body weight, height, so you know whether the child is thriving well, if he is overweight or not. On abdominal examination, one has to palpate, especially in younger child for Wilms tumor, neuroblastoma. One may find a palatable kidney when the child has a polycystic kidney disease. Hepatosplenomegaly may be present in the setting of ARPKD, or as a marker of hepatomegaly may be present as a marker of left heart failure in children with sustained hypertension. Again, in CVS examination, one needs to palpate all peripheral pulses to know whether there is any discrepancy, and look for BP in both arms and in one leg. One needs to look for cardiac murmurs and for abdominal carotid bruit. Also, again, LVH, features of LVH which may be apparent on examination. Among other examination, neurocutaneous disease like neurofibromatosis, Turner, Williams syndrome, all these may be associated with hypertension, and this is what one needs to look at. For complications, we know that hypertension is associated with papilledema or seventh nerve palsy. So all this may be available. We can visualize on examination. Initial screening involves urine analysis and measurement of electrolytes and urea creat with lipid profile and renal ultrasound. In obese patients, one also needs to look at HbA1c, AST, ALT, and a fasting lipid profile.
I think the other thing to remember is that the more severe the hypertension, the likelihood of a sinister pathology increases. So now we are seeing so many obese individuals and they may have marginal hypertension. But if somebody is non-obese, early onset, as we all talk about that severe disease basically, early onset and the BP is going up so high causing encephalopathy, you have to be more aggressive in terms of reaching the final diagnosis. On the other hand, if somebody is around 13, 14 years of age, mild hypertension, stage 1, stage 2, maybe even, and obesity is explaining, we don't need to be very aggressive, because if you are not clear, you have to be going more in deep into workup.
Definitely. As we know that primary hypertension is not usually the first thing in children, and secondary hypertension will usually present with much higher BP records as compared to primary ones. So the most important thing to remember here is that the child presents with an acute afebrile encephalopathy, and what usually happens, as sir has already mentioned, in any child with an acute encephalopathy, we jump to the conclusion of meningoencephalitis and subject the child to unnecessary antibiotics, CSF examination, which may be completely avoided. And so this child with acute afebrile encephalopathy had hypertension with BP greater than 95 plus 12 centile. All peripheral pulses were well palpable with no radioradial or radiofemoral delay. There was no significant discrepancy in BP nor.
This was when the child came to ask for evaluation, or at the beginning, because
so some of these were not picked up by the initial team, but I have pretty much summed up the examination findings here. He had no Cushingoid features, he had no neurocutaneous markers, and on abdominal examination, no mass was palpable. His lab report showed a borderline hypokalemia with levels between 3 to 3.2. There was one isolated value of 2.8 when he was started on thiazide for BP lowering, which was immediately withdrawn, and he was shifted to
this is a very important point which you have picked up, that often, as I was saying, that hypokalemia may not be present in everybody, but their whole body potassium is low. And if somebody starts on thiazide diuretic, suddenly you will have precipitation of hypokalemia. This is a classical picture of hypokalemia in endocrine hypertension. This is the first clue that you're probably talking about an increased aldosterone effect.
His RFT was in the normal range. His urine analysis showed a 1 plus albumin urea, but there was no nephrotic range proteinuria or hematuria, so rest of it was normal. Initial ultrasound KUV Doppler showed a normal renal parenchyma and vessel flow.
So what are you looking here now, Manoj? You have a child who has hypertension, has hypokalemia, has a normal renal function, normal KUV, and normal VMH. So what are you thinking of now?
Hypokalemia with the hypertension is pointing towards the endocrine cause, increase the RAS effect. So I would
will go for the screening for this RAS system.
Yes.
Correct.
So
and echo?
Yes, I'll be mentioning that further. So in this hospital stay, his encephalopathy was managed with supportive care. Seizures were controlled with AEDs. And for hypertension, it was initially managed as an emergency. He was screened for end organ damage and found to have none. IV antihypertensives were gradually tapered and he was shifted to oral. So even though sensorium improved, his BP was still remained between 95 to 95 plus 12 centile, despite being on 4 antihypertensives. And at this point, an underlying endocrine hypertension was suspected and he was referred to us. So we found that the examination was pretty much same as I had mentioned previously. The extra finding that we found was a renal bruit. So in a child with severe hypertension with borderline hypokalemia, like we've already seen, we expect a defected RAS level. But before jumping onto that, we also ruled out thyrotoxicosis and Cushing in this child. And as sir has already mentioned, for assessment of aldosterone level and PRA activity, we know that the child should have a normal salt intake for 3 days, should be off antihypertensives that affect the RAS axis, and 8 a.m. sample. The drug of choice that you need to shift the child to before doing this is verapamil, hydralazine, or prazosin. And we found that the aldosterone level was 85 with a plasma renin activity of 9. So, as we've already seen, so at aldosterone of 85, you expect the PRA to be less than 1. PRA of 9 at aldosterone of 85 suggests hyperrenism in this case.
This is a very, very high level of aldosterone. Now, we'll talk about primary hyperaldosteronism also, and we'll see that this level is pretty high from any level. That is why he was having such a severe case of hypertension. Now, if you talk about a primary aldosteronism because of an adrenal tumor, only the tumor is produced. So the level would basically not be too much. And the production will be dependent on some other factors. But if you talk about a renin excess, there is a continuous, like it's being flogged to produce a lot of aldosterone. And that's why the level went up to that. But your ratio was less than 10, which basically suggests hyperrenism. So I think what basically a big message which is out there is two. One is that you picked up a bruit in the abdominal examination. We could have gone directly for an imaging to look for angiography. But the reason we were a bit reluctant and we went for the aldo PRA, it might not have been required also. So if you say bruit is not required, the problem was that the ultrasound Doppler did not find the renal artery stenosis. So which means that the sensitivity of Doppler in picking up this is not good. So now carry forward.
Okay, just a disclaimer here again. We could appreciate the bruit only after we saw the CT report here. So it was not appreciated. So again, we got a 2D echo done and to rule out coarctation, and we did not even find a left ventricular hypertrophy. CT angio was done. So as you can see, the right artery appears completely cut off from the main abdominal aorta branch, and you can appreciate significant stenosis on the left side. The final report, so the final report showed severe stenosis bilaterally in the main renal artery as well as accessory branches. We also found stenosis in bilateral SMA and at the level of suprarenal abdominal aorta. So we know renovascular hypertension is because of compromised blood supply to the kidneys. 3 to 10% of children presenting with severe hypertension are found to have renovascular lesions. And it is the second most common correctable cause of hypertension, next only to coarctation of aorta. The most common cause of renovascular hypertension in Western literature described as fibromuscular dysplasia. However, in Indian subcontinent, Takayasu arthritis has been found to be the most common cause.
Aortoarthritis, tubercular arthritis,
post-tubercular,
factors. So if you have multiple lesions, fibromuscular dysplasia is usually a localized the renal artery. But if you have generalized, you will think of vasculitis in this scenario. So this is a very interesting case. So basically, the big message I would probably have is two. One is that anybody with encephalopathy measure blood pressure. That is for a general assessment perspective. And second, Doppler is not a very, very reliable test. It's an operator-dependent test. They may miss it. And anyway, you may miss that because he had a very significant stenosis. And maybe CT angio is a very good modality to pick up. This will be the key messages from here.
So just to end my talk, I would appreciate answers for this. What is this characteristic bleeding seen in? And what drugs, meaning what antihypertensives will you avoid in a child with renal artery stenosis?
You can all go and have a look at our website and explore our courses and the mobile application.